So, good morning and thanks for having me on this panel. A little long distance, as you can see, but it's an absolute pleasure. And thank you, Akiko, for all your guidance, including on the project that I'm going to talk about. Um, uh, so, what I'm going to do is to bring a little bit of the context from the Indian scenario and the work that we are doing on the UHC space in the country. And then, as Akiko mentioned, take a little bit of a detour into something specific that we are doing as a sample of the kind of work that we do at the World Bank. I'll be focusing on both harnessing the private sector and on empowering women in these couple of snippets that we'll discuss in the few minutes that I have. So can we have the second slide, please? I can't see the slides, so I'll have to assume the slides have been changed.
Yes, it's on. Slide 2 is on. Yeah.
No, perfect. No, I'm pretty sure that the system's very efficient. Let's talk about healthcare in India, the financing story as of the current period. So if you look at a country that spends 4% of its GDP, which used to be about $40 per capita and is now about $60 per capita as we speak in 2015. The country spends about $70 billion total on health per year, out of which the government spending is about 30%. But at $70 billion that we have, more than 17% of the world's population manages with just about 1% of the world's total health expenditure. And no wonder you have models that I was hearing intently about Dr. Devi Shetty being mentioned in the previous session. So no wonder you have a $1,500 bypass surgery, because even that $1,500 is beyond the means of most of the people who live here. So public spending on health, the share of the government spending is about 1% of GDP. It's about 1.2% currently. And it is significantly less than what other countries at India's income level would spend on health. The result, we have a very high share of out-of-pocket payments, currently at about 58-59% of the total health expenditure, which exposes the country to several million people or tens of millions of people falling into poverty every year. Now, this number is actually a substantial improvement over 70% of household expenditure that we would see a decade back. So it's a substantial improvement, but still there's a long way to go. And even at these levels of expenditure and with these challenges that you see, these are still talking about India on the averages. Now, performance for what we spend, even for this level of spending, is below par, and the averages do not tell the story of large disparities across states, that is geographical disparities, and disparities among social groups. So that's the second challenge that we face. And a consequence of this underinvestment in the health sector is a severe shortage of health workforce, especially in nursing and midwifery also in some states. And we'll just talk about it in a moment. Next slide, please. So this slide wasn't intended to replace your routine eye test at the ophthalmologist. Please do not skip that. But this, in a snapshot, does summarize in small font, because the numbers are small, the state-wise availability of human resources in the country. And if you look at the health worker numbers, you can see how these vary very widely, from a number as small as 3,000 doctors in states such as Jharkhand and Uttarakhand, which is now called Uttarakhand, and which is the state I will be talking about, to numbers which are far bigger. So Goa, with 1 million people, has the same number of doctors, roughly the same number of doctors, as an Uttarakhand with 10 million people. Delhi, with 1.5 times the population of Uttaranchal, has 3 times the number of doctors. And these numbers just get even worse when you look at the combined ratios of health workers. So 0.39 is the combined number for Uttaranchal state that we'll be talking about, vis-a-vis states which are lucky to have even 3.74, such as Andhra Pradesh, or even 4.61 in the southern state of Kerala. So you can see the huge disparities. India as an average at 2 per thousand may not look that bad, but when you see an Uttaranchal, which is 1/5 of the country's average or below 1/5 of the country's average, that's really the disparity I was talking about in the previous slide. And if you look at the ratio of nurses and midwives per doctor, which is the last column here, from a number such as 26 in the state of Himachal Pradesh, which is a neighboring state to my case study of Uttaranchal, it is a 100-fold difference with the state of Uttarakhand. So, what are the key health challenges that this hilly Himalayan state of Uttarakhand is dealing with? Our difficult geographical terrain.
Next slide, please.
It is a very hilly state located right in the Himalayas with a lot of access and equity challenges. Severe human resource constraint that I just showed in the slide before. I'm sorry, this is the next slide. This is the 4th slide.
It's on. It's on.
Okay, perfect. Thank you. So, in the state of Uttarakhand, as the previous slide showed, we're talking about severe human resource constraints. And again, you saw the country's average and how Uttaranchal was so much worse off than the country's average. But even within Uttarakhand, the plains get all the health workers and the hilly areas hardly get any. So it's a even deeper accentuation of the problem in the hilly and remote areas of the state of Uttaranchal. So this difficult geographical terrain with a lot of access and equity challenges also has to address a large seasonal floating population of tourists and pilgrims. Tourists who come to see the Himalayas and pilgrims who come to a state which has almost all the holy places in Hinduism in one state. So the number of pilgrims in the state is 3 times the state's population every year. The state is still dealing with maternal and child health challenges and communicable diseases, even as it undergoes an epidemiological and demographic transition, and also faces very high numbers of diabetes and hypertension cases. Plus, being in the hilly area and a very disaster-prone region, it has to really be prepared for disaster preparedness and natural calamities. And finally, there are financial protection issues, including unmet demand for health services. If you look at the number of people who were able to access hospitalization, Uttaranchal or Uttarakhand has some of the smallest numbers in India because of people either too far away from hospitals or just not being able to afford hospitals. Next slide, please.
Yeah.
So, if you look at, once more coming back to the country's context, what's happened in India is there has been a steady growth in the health sector. This has been one of the largest employers of women. There are new generation publicly funded health insurance schemes, one of which is now going to be enrolled in a big way in Uttarakhand also. Now, while women's enrollment is still low in many of these publicly funded health insurance programs, the utilization by women is proportionately higher, which is a bright spot there. And more importantly, these health insurance programs have created a way for the state to be able to partner with the private sector in a much bigger way than the past. And the scale at which this partnership has happened is unprecedented in India's health sector. So several million hospitalization, including several thousand from the cardiac hospital of Dr. Devi Shetty that was spoken about in the previous session, were funded by some of these publicly funded health insurance programs purchased from the private sector benefiting the poor and the informal sector and fully funded by public funds by the government, which has changed a lot of the paradigm in access in recent years. Still a long way to go. And one more contextual point about acute shortages in nursing staff amidst huge international demand. That's the other snippet about the India story. So while that has led to improved status and emoluments for graduate nurses, the second spin-off is that it has led to unprecedented private investments in nursing schools across India. It was never attractive to set up a nursing school even 2 decades or a decade back. And most edu entrepreneurs wanted to invest in medical colleges. But of late, nursing education is so much in demand because of the improved status and emoluments for nursing that this is a new wave that's sweeping, and it's also something that's happening in Uttarakhand. And before I go into final details of some of the solutions that we are trying to do in Uttarakhand, just as another small snippet of grassroots health workers in India called ASHA, the accredited, this is the next slide, please.
Yeah, it's on.
Are we on slide 6?
Yes.
Okay. So the empowering women as providers, particularly at the grassroots level, in linking the communities to the health system through these women, India, over the last decade, has actually deployed an army of 0.9 million, 900,000 women who were primary school educated women living in the village communities, and they've been engaged and trained to act as an interface between the community and the health system. So they take women for maternity, they take women for immunization, they take children for immunization, they inform about government programs, they act as providers of observed therapy under tuberculosis, and so on. And they are paid for each of these activities only on performance basis. They are not salaried workers, but they are small entrepreneurs who now learned what health programs of the government bring them what incentives, and they actually pick and choose about which ones they really spend their effort on. Almost all public health programs want to involve these workers called ASHA, and ASHA literally means hope. And these have become sort of another important story about entrepreneurship and women in the Indian health sector. Next slide, please.
It's on.
So this is my last slide, and I just wanted to bring forward the discussion that happened in the previous session on linking technology, linking improved services, and community accountability in the health system. And this is what we are trying to do in the state of Uttarakhand to address some of the challenges that we just discussed. At the core of this whole design is the patient, and making access easy for the patient living in a hilly area, particularly the woman who resides in the hilly area, or the old person who resides in the hilly areas, or the children who go to school in the hilly area, while their men folk are working more in the plains, and so the access to them will be facilitated using a health helpline and information come concierge come information technology platform service, which provides primary care information to the patient or escalates them to higher level of medical services if needed. In case of emergencies, it connects them to the emergency transportation system. In case of non-emergencies, which cannot be solved by over-the-counter advice, they connect them to both the physical infrastructure and the mobile infrastructure to be augmented under the project. So mobile medical units, as well as outsourced public health facilities in a networked, integrated, district-wide model would be made available through the health helpline itself to talk to the patient, to connect, get the appointment, and subsequently after the encounter, take their feedback on this experience with the health system. The whole physical and mobile infrastructure, because of the shortage of specialists in the locality, and because it is very difficult to get them everywhere, will be linked through a teleconsultation, telediagnosis, telemedicine system to a statewide backbone that links to remote infrastructure that has all the critical care doctors and immediate reporting back on radiology and immediate reporting back on ECGs through an outsourced environment. So hopefully being able to bridge the distances and being able to get over the geographical constraints faced by the state, as well as creating strong community linkages through the helpline and through the community workers who would stock over-the-counter drugs in the state for their needs. Wouldn't go into much more detail just because we have a limitation of time, but just a glimpse of what we are trying to address in this very difficult context. So it's back to you, Akiko.
Yeah, great.
Thank you very much.
Thank you very much, Somil. And I think this project, by the way, it's still under preparation, and we're hoping to present it to our board in a few months. So this is an example where we're trying to address a considerable amount of the value chain that was discussed before, and we have not yet moved towards results-based financing, but this is something that provides the context in which that could be also explored. And I hope that as the project moves forward over the next 4 to 5 years, that this could be another area of focal point and as well as innovation, that we're trying to do things in a different way within even in the public sector, bringing the private sector in. So, Somil, thank you very much for your intervention. I wanted to, at this stage, go straight to Kama. Dr. Kama Rogo is our lead health specialist. He is currently living in Nairobi, but obviously he's in Niger at the moment. He's a medical doctor with a background in OBG area. Please correct me if I'm wrong, but and who has done considerable work in the World Bank on reproductive health and maternal health issues over the years. But in the last few years, he had moved over to IFC, our private sector investment group. And just this past few months, because of our reorganization, he's back to being part of us. He's never left us, but I think that the fact that Dr. Rogo has been involved with our private investment group and is back now with us in the World Bank, which is with the sovereign, the government, public sector side, we really do hope that he will be the bridge and really encourage our investments and collaboration with the private sector. And today, I know he would like to talk about the Africa Initiative, where these private-public initiatives are being undertaken. And I know, Kama, you'd like to share with us the kind of work that we're doing, and we hope that you'll find this some more food for thought, and I hope you'll work with us, those of you who are here. So, Kama, can you hear me? And over to you.